Hello, welcome to today's webinar. Today's webinar topic is healthcare data analysis, finding, crunching, and displaying data for zero harm. Our speaker for today is Jay Arthur. He is well qualified to talk to us about this topic today. He does lots of talks on all the great work that he's done in the past. He teaches people how to turn data into dollars using Microsoft Excel. He helped a healthcare system reduce rejected claims by $24 million. He's the author of the Lean Six Sigma for Hospitals, second edition, Agile Process Innovation, and QI Macros Lean Six Sigma Software for Excel, which is a software package that automates all the charts and documents required for Agile Process Innovation. So well-qualified speaker today, and I'm just going to turn you over to him. The first thing just to tell you is we are going to have, we will post the recording, we will have the slides, and that you'll get in an email. And if you save your questions and put them in the chat, then we will answer your questions at the end. So thanks.
All right,
Jay, you ready? Take it over.
All right. Well, hi, thanks for taking time out of your busy day to learn a little bit about healthcare data analytics. Now, having been an ASQ for the last 35 years, I think oh, shut up, WebEx. I love how it intervenes, don't you? Anyway, so I joined ASQ in 1990, and been working through it. In general, ASQ has focused largely on manufacturing. In this country, manufacturing is about a $2 trillion industry, and healthcare is somewhere between $3 and $4 trillion. And ever since 1999, there was a book came out called To Err is Human that said healthcare is killing 100,000 people unnecessarily every year. That number was actually low. It's somewhere between 250,000 and 400,000 people. So anyway, I've started to work with healthcare on this, and I'm really chasing the idea of zero harm, right? Zero harm, no mistakes, no errors, hassle-free healthcare, fast, affordable, flawless, right? This is my goal, right? And I think ASQ has been somewhat reluctant to embrace service industries, but service industries are 80% of the employment in this country, and manufacturing is now down to less than 10%. So I think all of us have an opportunity to help healthcare, even if something goes haywire in the company you're working for at the moment. So, but anyway, let's talk about this whole process. Shigeo Shingo said your business is like a banana. It's 46% waste. Joseph Duran said it's somewhere between 25 and 33% waste. According to the Institute for Healthcare Improvement, which is sort of they've been around 40 years. I don't know why healthcare is any better, but anyway, they suggest out of the $3 trillion they say we spend, $1 trillion is for waste and rework. $1 trillion. And that's just on the healthcare side. That's not even on the patient and family side. I bet there's another $1 trillion over there. And so consequently, this is a huge opportunity, and I think it's important for all of us, right? For you, for me, for our children, for our parents, for whatever, because I want it to be better, all right? So companies are always going to need people like you who can solve problems using data. And I don't care if you're in manufacturing or whatever, you can use this in healthcare, you can use it in services, you can use it in banking. And so there's this great opportunity I see to transform the planet and this country. So where do you find data? Well, back when I started working in 1999, 2000, most of the records in healthcare were paper. All right. But since then, electronic medical record systems have come along, and they have things about harm and adverse events and whatever else is going on. There's accounting systems, which I used for denied claims to reduce denied claims by $5 million, and rejected claims by 24 million. And purchasing, and there still are paper patient records. They're manual and slow, but sometimes you have to go that far. I like to start with the automated ones first, because you can get all that data out of those systems. Big systems all export data into Microsoft Excel. And once you do that, then you can start to work on it. So in healthcare, I found there's 3 types of data. And the first one is time series data. And in manufacturing, you're probably used to, doing sampling and tracking things with control charts and so on. But in healthcare, it's mainly things like ratios, like falls per 1,000 patient days, VAP rate, which is ventilator-assisted pneumonia, things of that nature. And so those can all be plotted with a control chart. And Dr. Donald Wheeler calls the XMR chart the Swiss Army knife of control charts. And I have found that this thing can be very helpful. Now, there's actually, I don't even know if I can get to it. Oh, that was Wheeler's book. There's a rather large book, 600-page book called The Healthcare Data Guide, which walks through all the various kinds of control charts for healthcare. But I've found the XMR chart covers most of it. Excuse me. Thought I had to sneeze. I was getting there. I'm sorry. All right. So control charts for time series data. Next, there are counts of mistakes and errors. And there's lots of mistakes and errors in healthcare. The IHI estimates that 1 out of every 2 patients in a hospital, 1 out of every 2, suffers some sort of preventable harm. 1 out of every 2. That's not even 1 sigma, all right? So tremendous opportunities to improve all these things. Hassle-free, error-free, flawless healthcare. So here's things like pharmacy order entry errors, and we can take that and turn that into a Pareto chart. And that's going to be my go-to chart for a lot of the error kinds of data. And then when it comes to time, we want to use histograms and control charts, and we can plot things like radiology report turnaround times and time to thrombolytics. Time to thrombolytics is how long does it take for a patient having a stroke to get the drugs that bust the clot. And if it's under 60 minutes, you're more likely to retain brain function, and afterwards is more likely to be damaged. So faster equals better. Same thing with door to balloon time for people who are having heart attacks, to expand an artery or whatever. So those are the 3 types: control charts, Pareto charts, and histograms. We're going to do time series data, we're going to do counts, and we're going to do actual time itself. I don't know about the rest of you, but if you go to a lot of these healthcare facilities, you spend a lot of time waiting, don't you? Virginia Mason up in Seattle, a big medical center, really got into this about 12, 13 years ago and aggressively went after it. And they brought in Japanese counselors, just like you might to a manufacturing plant. And the Japanese counselors looked at the layout of the hospital, and they noticed certain areas, and they said, "Oh, what are these for?" And they said, "Well, those are waiting rooms." And the counselor said, "Who waits there?" And they said, "Patients." And they said, "Well, how long do they wait there?" "Well, 45 minutes to an hour and a half." And the Japanese counselor said, "Aren't you ashamed? Aren't you ashamed?" So anyway, there's tremendous opportunity to reduce this dramatically. So there's our 3 tools: control charts with a before and after. One of the things I do is I go to all these conferences. Next week, we're going to the Magnet conference in Atlanta. 13,000 nurses who are all working on improvement projects. To become Magnet certified, you have to do 200 improvement projects. 90% of the tools they use are Excel line, bar, and control charts, which I consider the 3 stooges of charts. But what we can do is use control charts, Pareto charts, and histograms, and I think they could tell much better stories that can be sustained over time. So I don't know if you're familiar. What's the biggest type of patient harm? What's the most frequent? What's the most costly? could be pressure injuries, could be patient falls, right? Sometimes they're bloodstream infections. Sometimes there's wrong side surgeries. There up in New England, one hospital system had 3 wrong side brain surgeries. How's that possible? And they did that in 1 month. So where can you find data about that problem? So I believe world-class improvements start with a control chart and end up with a high level 80-20 level Pareto. Most of you are familiar with that high level. But I have found when you drill down into that one, the same pattern exists inside the big bar of that Pareto chart. And I call it Arthur's 450 rule. 4% of what you're doing is producing over half the mistakes and errors and waste or work and patient harm and whatever. So we're going to drill down some more and then do fishbone diagrams and comparison control charts and Pareto charts. And we can also do that with histograms as well, before and an after histogram. And our control chart should also reduce. So one of the things that, we make the QI macros, which is an add-in for Excel to do all the charts for Lean and Six Sigma. But I realized that we really help automate Lean and Six Sigma. And lately, last year or so, Minitab has raised their prices to $1,850 a year, and it's an annual fee. QI macros is $375 one time you buy it, and you can upgrade when you want to, but $375 will get you going and do all the stuff. And I've also found that we are more than enough tool for healthcare. And a lot of black belts and master black belts use us anyway, anytime they're in Excel, because it's just easier and faster. So the QI macros have charts and wizards to automate Six Sigma. We have fill-in-the-blank templates to automate SPC, a stat wizard that automates hypothesis testing, and an improvement project wizard that automates DMAIC. So we can take and accelerate everything to get to results. Now, one of the things I have found is, yes, there are complex problems in the world that need a full-blown DMAIC or designer experiments or whatever, but there's not that many of those. In manufacturing, you may use DOE a lot because you're trying to design a widget to make sure it is as rigid or whatever it is as it needs to be. But in healthcare, not so much, right? I've never yet seen a DOE in healthcare. I had a friend who actually taught Six Sigma for GE Healthcare. And she said, well, we spend 3 days teaching them DOE, but she said, I don't know why, because they're not going to use it. And one of the things I have found is if you teach people things they don't need, it confuses them. It's overproduction. You're trying to stuff too much junk in their head. I believe that we need minimum viable training. And so I have a free yellow belt course on our website, and I'll show you where that is. But people don't need to know everything to solve everything, because only 4% of what you're doing is causing over half the mistakes. You don't have to know everything. You don't have to fix everything. You don't have to know every tool. So there are simple problems, and you should just fix those. But most problems are a little more complicated. They need data and the 7 key tools. And I was sort of in between PDCA and DMAIC. I came up with my own acronym, which is focus, then improve, then sustain that level, and then honor your progress. So those things are essential. I mean, it's a simple process. It's all the same process. And as I mentioned before, you all know about Pareto's rule, the 80-20 rule. 20% of what you're doing is causing 80% of the mistakes and errors and lost profit. But within that 20%, the same rule applies, the same power law. So as little as 4% of what you're doing is producing over half the mistakes and errors. Sometimes as little as one thing out of 1%, one step out of 100 is producing half the mistakes. So we want to go find those things. And then the other thing I've found is you don't need to know everything there is about Six Sigma to start making improvements. A handful of tools will solve most of your problems. Learn those, then add other stuff later. I think very often we try in our 2 and 4 week black belt and green belt trainings, we try and stuff too much junk in people's head. and we're trying to prepare them for a job in manufacturing when jobs in manufacturing have been shrinking. When I first started with ASQ in 1990, I believe there was 120,000 members. And now, 30 plus years later, there's only about 40. So feel free to think on that, right? It's been shrinking. So we need to find the right tools and get people going. And I will ask, if you get a chat question that applies at the moment, feel free to jump in and ask it to me over the with your microphone, and I'd be happy to try and respond. Okay, so what are the Magnificent 7 tools? Well, we have this advanced technology for lean, right? Post-it notes. I even have a little arrow post-it notes. Now, in manufacturing, there's not a lot of delay between things. But in healthcare and any service industry, most of the delay is in the arrows. So what does that mean? You don't need to do tack time and changeover time and all the other happy hoo-ha we do in manufacturing. You just have to find a way to shrink the arrows. And so this is the advanced technology. And I have found that most of the delay is just people waiting, patients waiting for something. All right. And then we're going to have control charts and Pareto charts or histograms and fishbones and some matrices. And there's one more tool that I've found we do not teach much in Six Sigma training, and that's the Excel pivot table. And so this is how you can summarize raw data that comes out of these big systems. So we're going to start with a pivot table, control charts, Pareto charts, fishbones, countermeasures, and before and after charts. I rarely ever see these kinds of charts at conferences, these kinds of stories. Last year at Magnet, I'm telling you, we're going there next week. I walk around and I do a stroke tally. I do a stroke tally of the types of charts that are used, line, bar, pie, whatever, because I started tracking this like in 2015. It's essentially unchanged for a decade. So line bar charts were 60% plus line plus pie charts. That 90% of the tools they're using are primitive last century Excel line and bar charts, not control charts, not Pareto charts, not histograms. And I believe you can't actually sustain or achieve zero harm with those tools. You can see this one has a few control charts, a Pareto chart, and one histogram. Not much going on out there. The Institute for Healthcare Improvement Conference is in December, and this year it's going to be in Anaheim. And so we'll be exhibiting there. But when you look at this, bar and line charts are neck and neck, but they're 2/3 of the total charts. And I've been nagging them saying, you ought to force people to use the tools of quality, right? They use some run charts. There's a Pareto, there's a control chart, a histogram or two. But again, not using the tools of quality. And I will tell you, I talked to a lot of section chairs and so on in ASQ, and they say, well, our people are weak in the tools of quality, the charts. And I say, how is that possible? We're the American Society for Quality, for God's sake, But I do have free training on my website to help people learn things that they might need to learn. So let's talk about why do we need control charts for what's called evidence-based practice. You haven't heard that word before? This is the John Hopkins book on evidence-based practice, right? So the idea here is we want to use evidence to prove that we're making improvements. In 2006, almost 20 years ago, I saw the keynoter, Don Berwick, present, Dr. Don Berwick, and he asked everyone there to pledge allegiance to science and evidence. Pledge allegiance. And then 10 years later, I saw him again at the closing keynote, and he said, I'm trying to get you people to pledge allegiance to science and evidence. And as far as I know, it hasn't changed much. So why control charts? So control charts help detect unstable conditions, which you can't do with line and bar charts. If you're familiar with line and control charts, you know that's true. So here's some examples. Now, I go to these conferences and I walk around and I'm doing these stroke tallies, and I see, I'll call her Nurse Betty. Nurse Betty is sitting in her nice blue pantsuit, comfortable shoes, because, you get tired from walking around these conferences. We actually give away Band-Aids at these conferences because a lot of nurses will bring new shoes or bring high heels, and that after about 2 hours, their heels are wearing out. So we're giving out Band-Aids like crazy. You'd think they would know this, but who knows? Anyway, so this is a chart of catheter-assisted UTIs. Christopher says he's a big believer in QA macros. So anyway, but these urinary tract infections are a problem. And here you can see that there's a trend line, but most of these never have a goodness of fit metric on here. The goodness of fit, the R squared, is about 30%. Well, I wouldn't want to bet my career on that, but I see Nurse Betty there reading the poster, and she takes out her phone, takes a picture of this like it's gospel, and she's going to go back and implement it at her hospital. Now, what is she going to do? Probably waste a lot of time and energy and wonder what the heck is going on. So they actually gave me the data, so I put it in, and here's a nice stable chart except for one out of control point. So we have a nice stable process. There was no improvement per se. And I have found that very often people think that special cause analysis is quality improvement. No, that's just special cause analysis. Quality improvement involves reducing variation or moving the center line. Now here's another one. This is hospital, another type of infection called C. diff. If you don't know, hospitals have the best bugs, so you want to stay out of there as much as possible. But I took their goodness of fit metric was a little bit better. And it turns out that when I put that into a chart, there was actually a process change. And so I think that the control chart with a process change tells this story so much better. And I want you to get an idea. If you see a chart with a trend line on it, it's just fake news. And you should treat it as fake news unless there's an R squared value. Now here's another one that had a goodness of fit that was really good. But again, if we show it as a control chart, opioid administration, they got their non-compliancy down quite a bit. And I've talked to a number of folks. We went to the Colorado Lean Network conference recently, which was at Children's Hospital here in Denver. And I was talking to one woman, and she was working at one of the hospitals. And turns out that, too much fentanyl can be a problem, and it makes it difficult to get patients out of the hospital or into a bed or into wherever. And then they have to go on diversion, which means that, ambulances can't come to the hospital. They have to go somewhere else. And diversion is a very expensive problem. I worked with one hospital here, and they had like 20 hours of diversion a month. And they estimated that for every 5 hours of diversion, they lost one heart patient that would be worth $150,000 to the hospital. So that means they were losing $600,000 because of diversion. And part of it's because of opioid administration. So there you go. This is a nice way to show the improvement process. Here's another one where they improve their safety event reports. Here's another one, hospital-acquired pressure injury rate. And again, these people here made one process change, and I think you can see down here at the very end, they had more than 8 points below the center line. There was actually another process shift at the end. So this shows dramatic improvement over time. And I think this is the kind of thing we're looking for. At the Colorado Lean Healthcare Conference, the Children's Hospital folks put up some of their posters, and all of their posters had really good control charts with really good process shifts. And I was so excited. I actually did an insight video about that. So I want you to get this idea. Nobody can get to zero harm, zero defects, whatever, without control charts. There's a whole move in healthcare to get to HROs, or high reliability organizations, which use control charts and whatever to drive infection rates, mistakes, and errors to zero. So that's what's going on in certain places, but not everywhere. So I don't believe you need to learn formulas. That's not necessary. When I first learned, I had to learn how to calculate these on a handheld calculator back in 1990. That was no fun. QI macros will do that for you. And one of the things that's unique about our software is where other people ask you to select a chart. So Minitab has a whole assistant that says, here's your decision tree, and we'll walk you down through choosing the right chart. Everybody else asks you to pick your chart first. QI macros ask you to select your data first. This is how Excel did it, so I did it the way Excel does stuff. This turns out to be the key to automating a lot of Six Sigma things that people have a hard time learning, like decision trees. So in 2006, I took this tree and figured out that because you've selected your data, I can build that into one of our charts, chart wizards. So, nope, that's where am I at? There we go. So if we have something like this, falls per 1,000 patient days, I can select that with my mouse. If you want to do it, you can go choose your own chart. But I've created this control chart wizard, which automatically will say a single column, decimal data, has to be an XMR or individuals and moving range chart. And it'll build our chart for us. And here's a couple out of control points. Looks like a downward trend. Maybe there was a process improvement. Another thing that I found people had a hard time doing was showing process improvements. So in 2017, I created a process change wizard. So you have a QI macros menu. You come over here to the QI macros chart, and we have a whole bunch of things. You can add text to points and do all kinds of crazy stuff. But we have a process change wizard. And it'll look at that data and say, where there's a trend or a run, I can adjust the limits. So we can go from the before to an after very quickly. So that's the improvement, the control chart wizard. We have chart wizards and improvement project wizards and stat wizards, and I'll show you all these things. We have a control chart templates wizard that'll pick a template for people. One of the things the control chart wizard does is pull out one of our templates and drop the same data in here. And then once you have the data, then you can just keep adding data to it. And the chart will grow as you type. And what does this do? It makes it very easy to do statistical process control, because all you have to do is keep adding data to a chart, update things. And so that's a powerful tool for getting people to do SPC. One of the things I find a lot is that, people do DMAI, but they don't do the C part. And then they wonder why their improvement goes away. Well, guess what? That's why. So just select the data, click on a wizard, and it'll choose the right chart or stat automatically. Now this collapses the training cycle time for training new people. Right? I don't have to teach them decision trees. If you've ever tried to do that, you know that it's not as straightforward as you might think it was, right? So control charts are the thing that are going to sustain those gains. Otherwise, the force of habit will push you back to about a 4 sigma. Most healthcare data is about 4 sigma, or a 1% error rate. Now, that means out of 44 million admissions in the United States of America, somewhere between 250,000 and 500,000 patients die due to a medical mistake. So if you're taking a loved one in, right hurt on these people. They're not, the systems are designed to let them fail. So I always tell people, what do I think the important patterns are? Well, number one, you want to reduce variation. Ta-da. Duh. Six Sigma 101. And then the other thing we want to do is reduce defects, mistakes, and errors. Or we can increase patient satisfaction or whatever. And so that's those things are really powerful. And once people understand what they're trying to achieve, I found that they are really good at doing that. All right, so let's also talk about Pareto charts. Now you can take a dumb bar chart and a dumb line chart, and you can combine them in an intelligent way, and they become a smart chart. By the way, I switched from saying statistical process control to smart performance chart. Still SPC. These are smart performance charts. And I think that makes it easier for people to swallow, because nobody likes statistics, nobody likes processes, nobody likes control. So anyway, side project there. So what is a Pareto chart? So we have descending counts of mistakes and an ascending cumulative percent here. So patient falls, medication errors, and pressure injuries are 2/3 of the total types of patient harm. So we fix those three things, we're going to get a 50% improvement. Now we don't have to worry about all the other stuff. Don't get distracted. So let me show you how that works. I think you can see here we have medication errors, wrong technique, time, dose, whatever. And after 18 months, it's been improved. So we can take these two things and select them. Right next to the control chart wizard is my next favorite chart, the Pareto chart. And it'll take those two columns and build Pareto charts for each one. And one of the great things you can do, once you've created a chart in QI macros, it's just a chart. And so you could change titles or whatever you need to do. But the other thing I want to do is, this is 30 and that's 30. So I actually want to shrink this down a bit. So I line up my 30s and I can show how much I've improved. The other thing we can do here is Excel has a whole bunch of tools here, arrows and flow charting things. It's like a little mini Visio. And so you can just show that we've had this reduction. And I think that tells a great story about what's happened. Before it was wrong technique, wrong time. Now wrong time is the big one, and wrong technique has gone down dramatically. So that's our before and our after. And again, this is, I can't tell you how important this is to telling a great story. Back in 1989 and 90, when I got trained by Florida Power and Light, they were all, their Qualtech group was all about telling a good story. And I inherited that thinking from them. And so I think control chart, Pareto chart, fishbone, just in sequence is the thing to do. And we want to use histograms for time. If things are spread out, we want to move them to the left. Too much variation, reduce the spread. If you think about yourself as a patient, how long do you want to wait to see a doctor or nurse? 0. All right. How long do you want to wait for diagnosis or treatment? 0. You're going to get to 0. But back in 2004, Robert Wood Johnson Hospital out in New Jersey got the Baldrige Award. And I read about them in probably a Quality Progress somewhere. But they had set a goal. You will see a nurse in 15 and a doctor in 30 in the emergency room, or your visit is free. Nurse in 15, doctor in 30, or free. Now, guess what? They didn't give away a lot of money because they had found ways to collapse the cycle time to make sure that they could achieve that. So this is the kind of thinking that I think can be so powerful in healthcare. Now, let's go over see if I can find my histogram data. So here's some time to thrombolytics data from a book called Data Sanity by Davis Balistracci. And we can select the before, and we could take that and draw a histogram. Sample size. The upper spec is 60 minutes, and the lower spec does not exist. We had canceled. And so here's our time to thrombolytic. So once you get beyond 60 minutes, it starts to cause patient harm. You can see we had a couple that out here that were out to 2 hours. And so that's problematic. Now we can also come over here and select our data and come back over and run another histogram. Again, our upper spec is still 60. We have no lower spec. And so now you can see we have everybody inside of our 60-minute window. Now I can actually take that and I can copy it. I can go back over here and actually paste that in. And I could come in and use Excel's drawing tools to show that we had made a significant reduction and gotten everything inside of my upper spec. So before and after. So control charts, Pareto charts, histograms, we can demonstrate these things successfully and pretty easily. And I would love to see this kind of improvement project at the conferences. So line bar and pie charts aren't going to do it for you, but control charts, Pareto charts, and histograms will, because they went to college and they took statistics so that you don't have to. I just edited another Insight video. Half the people on the planet in this country are terrified of math and statistics. Terrified. And so what do we want to do? Well, let's put the statistics in the software, and all you have to do is understand the chart. That's so much easier. Now, once we've got all of those charts, we also want to be able to no, I do not want us to do that. WebEx has asked me if I want to include computer sounds. No, I don't want to include computer sounds. Gosh, it won't let me shut down either. Well, maybe it'll let me. Shut up. Unbelievable. WebEx annoys me. Anyway, so let's talk about crunching raw data like this: by date, by hospital, denied insurance claims. We want to take those and turn those into pivot tables, and then count and categorize things, and then select the right charts to make improvements for action. Most of the data I see out here is overcooked. Overcooked. And what do I mean by that? It's summarized by quarter. So this is deaths over bypass graft surgeries. It has little nutritional value. It's hard to do any quality improvement on it, so this is problematic. So I want all of you to go on what I'd call a raw data diet. Raw data diet. And what does raw data look like? Well, it looks like this: by hospital, by admit date, denied charges. So if you know the where, and you know the when, and the what, guess what? That was worth $5 million a year. If you have data that looks like this is pressure injuries, you could potentially eliminate pressure injuries. Because we have the when, the where, the what. I wonder what this thing won't let me close that. Oh, well. I hope you're not seeing this WebEx nonsense that I'm seeing. But we might. All right, so first, I have to tell you, this was a weird thing. It was a long time ago, but it's a great story. So I was invited to come work at this hospital. They'd been trying to figure out what was going wrong with denials for 9 months. 9 months. People working on this, trying to figure it out, and they were being unsuccessful. And so they brought me in. And it was so funny because the first thing he asked me is, they said, well, are you a doctor or a nurse? And I said, well, no. And that's great for you. And I can tell you why. Because I'm not buried in all of your limiting beliefs about how all this works. So I'm going to look at your data and see if I can figure it out. So they had 47,000 rows of denied insurance claims, almost $150 million a year. I think I only had 9 months of data, so $150 million. That's a lot of money, all right? So I started doing pivot tables, and then I figured out how to draw a control chart, and then I tweaked the pivot tables and started looking for Paretos and so on. So this is the story. So I found that on average, there was $1 million something in denied insurance claims. And then I drilled down using Paretos. This is my 80-20 level Pareto. All right. $8 million were for timely filing. That's the big bar. So let's go fix that. All right. And then I drilled down into timely filing. And I found that one insurance company was 2/3 of the total. This is exactly the 450 rule in action, right? And it turns out that just one insurer. I got people together for a couple of hours on a Friday afternoon, and we came up with root causes. One of the things I found that when you come down to this 450 level rule Pareto, it will actually give you a minnow bone diagram, not even a fish bone diagram. If you ever find yourself whalebone diagramming, you need to refocus. All right. So these are what I found. And they came up with some countermeasures. They came up with something to do internally in their procedures. They implemented that on a following Monday morning, next Monday. And they were able to reduce denials by about 400,000 a month, $5 million a year. We also found ways to $24 million would be rejected. They'd go out and they just bounce right out. So we found ways to fix that. And then they had an appeals process for claims, and it was running 300 days. Now they had $100 million waiting 300 days to be appealed and approved. We got that down to 45 days by getting rid of what? Arrows. All right. So not too complicated. So at the time, I started realizing that maybe I could automate that because I'd done it enough times repetitively. I said, well, I think I can do this. I think I can do this. Turn this kind of data into an improvement project with just one click. So we can take that and turn it into data. So let me show you how that works. Boy, I wish I could get that thing out my way. You guys are going to make me mad, aren't you? All right. Well, I'm going to have to do this the hard way, aren't I? The screen from WebEx is right in my way. So here you can see we have some data by date, by unit, type of patient arm. So this is nursing unit. All I have to do is select two of these headings, go to QI macros, and click on the improvement project wizard. Now I used to try and teach people how to do this, but I found it's just about as hard as choosing the right chart or something. And so I said, maybe I can automate this. And so I found that I used to spend 3-4 hours to 3 days doing this analysis. And now I just use the improvement project wizard. So with one click, it came up with a control chart and 2 projects. At the high level, it comes up with an 80-20 level Pareto. Then it took the big bar, drilled down, and found a 450 level Pareto. And from that, it invented an Ishikawa diagram with a problem statement. Anything you have in there that I can use, I turn it into a problem statement. I found that people sometimes are not that good at making problem statements either. So let me show you what all it built from that raw data. So it gave us a control chart, nice stable process, about 8.5 a day. Which nursing unit, Unit 3 had most of the patient harm, and within that, patient falls were 40% of the total. And it created a fishbone. But it doesn't stop there. It keeps looking. It's going to keep looking. And so here you can see patient falls, medication errors, pressure injuries. Patient falls were the big bar. And it drills down into that and finds out that Unit 3 has most of the falls harm. I was talking to one nurse at a conference. She said, "Oh, yeah, we found exactly that. It was men between the ages of 20 and 40 in the orthopedic recovery unit who were crashing." And I thought, well, yeah, I think the nurses in that unit could figure out how to keep men between 20 and 40 from jumping up and trying to run around. They make these little pressure sensors you can put on the bed, so if somebody gets off, it alerts somebody that they're trying to jump up and run around. And then it creates a fishbone diagram. During 2020, Unit 3 accounted for 79% of patient harm, patient fall. So this is a really good improvement story. And now the great thing about this, once you've done this analysis, you know who should be on your team. You don't need nurses from Unit 1 or 2. You don't need a random selection of people. You need people from Unit 3 who know something about patient falls. And I've found that when you do this, you get the right people in the room to do analysis. If you don't do this, you get the 100-yard dash from the directionally impaired. People want to go fix this, that, or the other thing. And so we don't want them to do that, all right? So that's the improvement project wizard. Builds entire improvement projects right from your thing. Now, I wrote a book called Agile Process Innovation, Hacking Lean and Six Sigma for Results, which I'm going to talk about here for a second. I also wrote Lean Six Sigma for Hospitals. A lot of people love that book. But the Agile process I have found, people like Chris's Health and others have actually adopted this. And so here you can see, first step is pre-work. Select teams that have a real problem to solve with data about that problem. Now, what I normally do is make sure that they have the data, and I look at it to see if there's an improvement project in there. Then, in one day, you can train teams in key improvement tools and apply it to their data and their problem. One day. Sometimes two, but one day usually will do it. And then you implement countermeasures and measure results. And Chris's Health found, they were doing the big black belt, green belt, Six Sigma thing, but weren't getting results. And their leadership team said, well, you're going to have to train people in a day or two and start getting some results. And they all freaked out, but they came up with this process. I started doing this in about year 2000. So I've been doing 25 years. But they found that they could train people and get results. They started getting results immediately in a day or two. Right? And that was just outstanding. Now, guess the other thing that they discovered from this was out of 20 people and 4 teams and 20 different people in the room, 2 or 3 really showed the aptitude for ongoing improvement. Let's take those people who we've identified and send them off to advanced training, to green belt or black belt training, because then you get people who really want to keep doing it. I go to a lot of conferences. I've talked to a lot of consultants, and they say, well, we train people, they do one project and they quit. They even have a phrase for this. They call it one and done, one and done. And I think that's a waste of time and money. So let's find people who are really enamored or excited about doing this. So that's the nuts and bolts of it. Control charts, Pareto charts, fishbones, before and after charts. Right? Narrow your focus. Apply that 450 rule. Drill down. And one step of every 25 is creating half the waste, rework, lost profit, patient harm. That's the $1 million misstep. Let's go find that thing. And I do believe with a little data, QI macros, and a little bit of training, you can create results and create what I call a money belt. All right, so let me show you. If you go out to our QI macros website under free training, we have free QI macros video tutorials. And you can click on QI macros for healthcare, manufacturing. I have like a 1-hour workshop. The QI macros all work the same. Select some data, click a button, get a chart. So once you understand the process, it's pretty simple. I have a free yellow belt training out here, as you can see. And we charge for certification, but the training is standard. And we actually have healthcare case studies and automotive case studies. There's a lot of information and guidance out here about how to do that. One guy, Colin, came up to me at last year's IHA conference. He took my yellow belt and QI macros and helped his company save $5 million last year. $5 million. So I know it can be done. And then I also have an Agile Lean Six Sigma trainer training. So if you want to learn how to train like I do, get people done in a day, that's great. And I'll scroll down here a little bit. At the bottom on the left-hand side, you can see we have my Agile Process Innovation ebook, action plan, and prescription. So there's a actual PDF copy of this book, just revised this year, of Agile Process Innovation. This is what I use to train people. It's 16 pages long. I don't know if you can see behind me, there's some big 3-ring binders for all the training I went through. Now I've narrowed it down to about 16 pages. And we have a quality improvement prescription. So here you can see it. Here's our Lean Six Sigma cheat sheet. You're welcome to print that out. Our 4-hour Lean Six Sigma hack and our 4-minute Six Sigma hack, the Improvement Project Wizard, to build improvement projects quickly. So that's a high-speed tour. I think you get the idea. We can go from gut feel and common sense to analyzing data to hassle-free healthcare. So I think companies will always need people like you who can solve problems using data. And healthcare needs you a lot, right? And we'll automate the number crunching so you can be a problem-solving genius. You can take my yellow belt training, the Agile training, get to QI macros, which automates Lean and Six Sigma, the charts, the SBC, the stats that I make, to speed things up, because I think we have to get faster. There's not much time next. If you want to know more about QI macros, there's an upcoming QI macros webinar. It'll be in November, and download the 30-day trial if you want to. I'll also show you, where am I? Where is my, oh, there it is. If you go out to the QI macros, there's an Improvement Insights blog. Every week I do like a 3-minute video about various and sundry things. This week was about using the 450 rule for emission testing. Posters at the Lean Six Sigma conference. The next webinar you can get to there. I did an Agile webinar. Anyway, you can keep scrolling down through here. I did a healthcare data analytics. But anyway, you can get to all of the information here. And happy to train people. I think that's the way forward. And I don't know if you can see it, but at the bottom of our pages, we actually have a chat button. If you have questions about QI macros or about your data, we're more than happy to help. You can chat in during business hours. So that's it. Lean Six Sigma for hospitals. And we're not a subscription. It's no annual fee like Minitab. So you can get tools to do everything you need to do very quickly and easily. All right, so I have just about run us out of time, but you know, let's see if there are any questions anybody wants to ask.
Well, thanks so much for that. That had a lot of good insights and tips on how to look at data. Really appreciate you doing this webinar for the ASQ Stats Division. I think you were very clear because I don't see a lot of questions coming through. So you still have a minute or two here to ask your question if you do have a question.
Jump right in. Anything else I can answer for anyone? Everybody's giving me thumbs ups.
Yes, you're
Emojis.
getting a lot of really good comments and everything, but I don't see any questions.
All right. Well, thanks, and let us know how we can help you. If you know anybody in healthcare, we have this video online. If you know anybody in U.S. military or their family, they can all take my yellow belt training and certification for free, no charge. So anybody in health in the U.S. military can get in and take that training for free.
We did get our first question.
Okay, what did it say?
Are those Andy Warhol pieces of art on the wall behind you?
No, that's a guy who photographed the Beatles. I can't remember his name right off the top of my head, but they're actually photographs. And so those are prints of John, Paul, George, and Ringo.
Very nice. Okay, well, I think we're going to end the webinar for today. I appreciate everybody coming and especially our speaker, Jay Author. And we hope you attend another webinar that we put on. See you soon. Thank you.
All right. Bye-bye.